Osteoarthritis, along with rheumatoid arthritis, is another problem which is more of a menace, especially when we are dealing with the knee joint. But the main factor is that osteoarthritis affects mainly the knee joint, and usually the next most important joint which is affected by the osteoarthritis is hip joint. But while on the rheumatoid arthritis usually affects the hand and upper limb and elbow joint more as compared to the lower limb. But again, it's a kind of a degenerative disorder which progresses over the period of time with some modifiable as well as non-modifiable risk factors. This is a normal knee. If you see, this is menisci. It is actually the distal part of the articulating surface of the tibia, and the femur is actually covered by a hyaline cartilage. Then there are around it intracapsular ligaments, and then you have a capsule and covered by the synovial membrane, and then outside you have extracapsular ligaments. As you know, the normal knee is a modified rotating hinge type knee, in which you don't have only flexion extension, but you have some degree of rotation as well in the axial plane. Therefore, it's sort of a not only a hinge joint, it's a modified rotating hinge joint, which is important to know because in knee mechanics, once the cartilage destruction starts to occur, over the period of time, this may be associated, as it's a chronic degenerative process, it may be associated with aging, it may be associated with trauma as well. But once this destruction starts to occur, this leads to exposure of the subchondral bone, loss of cartilage and chondrocytes, and eventually this biomechanics gets disturbed. Why? Whenever the knee is going to flex or extend or rotate, it's going to create or cause pain during this motion, and therefore eventually this is the classical presentation is old lady and old man coming with a knee which is actually the common point is that whenever I climb stairs or come down from the stairs, my knee starts to hurt. Why? Because when you're flexion extending the knee during your movements, this rotating hinge may produce symptoms which lead to chronic pain and problems. And why this happens? Because there are certain risk factors. For example, there are modifiable risk factors and non-modifiable risk factors. Non-modifiable risk factors may include gender. For example, females are more predisposed to this disease and osteoarthritis as compared to the men. And then other non-modifiable risk factor includes aging. This is usually associated with degenerative aging. Rarely you see osteoarthritis in young patients unless there is a specific cause. Usually it's seen in 40s, late 40s and 50s. If you're talking about other non-modifiable factors, one of them is genetics as well. Certain people are more predisposed to this problem because of their genes as compared to other people. For example, African Americans rarely undergo arthroplasty for osteoarthritis as compared to Hispanics or white. Usually white population and Hispanics are more prone to development of osteoarthritis and eventually going for total knee replacements as compared to African Americans as well. So these were one of the non-modifiable factors. Coming to the modifiable factors, there are multiple other factors which may be leading to osteoarthritis, like for example, obesity. Nowadays there is a pandemic of obesity as well, because with the advent of fast food and all the fast lifestyle, and everybody is becoming a couch potato, because as a result this is leading to actually an explosion of weight, and the people are becoming more obese day by day. This leads to a syndrome called as metabolic syndrome X, which may be associated with obesity, dyslipidemia, and multiple other causes other as well. All these actually leads to increased development of arthritis in the knee joint. One is that if you're overweight, your knees will have to bear more weight over the period of time, and this is actually leads to during every cycle, that is during every flexion extension, when you're going up the stairs or coming down from the stairs, all during this cycle there's extra weight and extra forces which are acting on the knee joint, and these extra forces will lead to increase in wear tear of the cartilage and would lead to early formation of arthritis and eventually osteoarthritis development in the knee joint. Then some of the other modifiable factors include, for example, one can reduce his weight, but one can get treatment for the dyslipidemia, Then as well, certain exercise which is actually important as well. For example, those people who have tendency to who have a sort of a doing work like going up the stairs or coming downstairs, for example they are laborers. In that case they are more prone to development of arthritis. These circumstances can be modified, and therefore development of arthritis can be slowed down. For example, instead of developing arthritis in early 40s, they may eventually develop in the late 50s or in the sixth decade of life. If you see these diagrams, this is the healthy cartilage. You can see a quite glistening whitish pinkish type of a cartilage, because it's usually avascular. It absorbs all the nutrients from the side, and therefore this is a normally, you can see the cartilage. This is actually elbow. If you see, this is the part of the trochlea as well as the radial head. But as it starts, initially the synovial proliferation and hypertrophy has occurred, and eventually you can appreciate that there are craters being formed in the hyaline cartilage. This whitish area is actually where the subchondral bone is actually exposed. The more white they are, this means the more problematic it is, because the subchondral bone appears to be white, while a healthy cartilage, which is usually hyaline, appears to be quite pinkish whitish in nature. Therefore, these, if you see clearly, this is the area where arthritis starts to develop, and you can also see the osteophyte formation over the tip of the olecranon. Why this starts to happen? Because osteophyte formation, subchondral bone sclerosis, and chondrocyte proliferation leads to this during every movement. Whenever that patient would flex or extend the knee, would lead to pain and eventually lead to further inflammation, and this starts to become a vicious cycle. Now coming to the clinical features. Clinical features of osteoarthritis, actually mostly when you ever they come with the patient, usually have overweight. Why? Because with overweight is a predisposing risk factor for development of osteoarthritis, and they usually, you see obese people developing problems faster and much more severe as compared to the non-obese people. Then is the pain. Knee pain is actually due to exposure of actually nerve endings in the subchondral bone. Cartilage has been destroyed, underlying subchondral bone has been exposed, which leads to the quite of the knee pain. And knee pain may be very common, especially during the movement which involves flexion and extension during every cycle, especially when climbing stairs or coming down from the stairs. Classical history is usually whenever we climb stairs or come down, we tend to have a lot of pain as compared to walking on a plain surface. Then stiffness. Stiffness starts to develop because whenever there is wear and tear and cartilage destruction occurs, this leads to increased synovial proliferation and effusion in the knee joint. This effusion or swelling which is produced leads to stiffness, because now initially there is a lot of fluid behind and around the knee as well. Therefore, the normal function of the knee is to flex and extend. It actually cannot happen. Therefore, overall they feel the knee is relatively more stiff compared to the other knee. Then swelling and effusion occurs. Why this occurs? Because again, cartilage has been destroyed, subchondral bone has been exposed, there is increased proliferation of synoviocytes, and synovial hypertrophy leads to increased synovial fluid production, leading to swelling and effusion, which may eventually get infected as well, and there may be locking or catching sensation as well. Why? Because once the meniscus starts to get involved, there may be associated micromeniscal tear as well, and this may patient may present with locking and catching sensation and some symptoms of a meniscal injury, but actually there was no trauma or no something like that. But eventually what happened was that osteoarthritis affecting the all the parts of the joint, like the cartilage, bone, as well as the meniscus and soft tissues as well. Some of the clinical features, when you get detailed history and examination, you see certain specific parameters, and one of them is actually the genu varum. The most common formation is of the genu varum in case of the osteoarthritis. The reason, because we are overweight. Generally, if you see that line, our weight bearing axis passes this called one is called anatomical axis, this is called mechanical axis. Mechanical axis starts right from the center of the femoral head, goes to the center of the knee joint and then to the center of the ankle. Now when this is happening, it's although not exactly in the center of the knee, slightly medial to the center of the knee, but it almost goes through like this. Whenever these obese people are usually patient, old age patient, because of osteoarthritis, their mechanical axis is going towards to mostly slightly more medial as compared to the normal mechanical axis. As a result, what happens is, if you see this x-ray, this is probably left knee, because we can appreciate the fibula over here, and this is the lateral side, this is the medial side. More weight has been transferred from this side as compared to this. You can clearly see there is just joint space. Look at the joint space of this side. There is marked joint space reduction. You can appreciate there is lipping as well as the osteophyte formation over here. There is subchondral sclerosis, increased whiteness, which can be appreciated because of the exposed subchondral bone, and some subchondral cyst may be seen over here as well. These are the classical symptoms you see on the x-rays. There's a Callaghan and Lawrence system as well, which actually analyzes whether what type of grade arthritis it is on x-ray AP joint of the knee. Whenever you have suspicion that the patient has developed osteoarthritis, what you get is you get detailed history, examination, you order certain blood tests, but before that you order the certain radiographic evaluation. And the mainstay of the radiographic evaluation is x-ray knee joint, AP and lateral view, which is mainly the weight bearing view. Why we need a weight bearing view? Because if the patient will not be weight bearing, we cannot exactly assess how much the joint space narrowing is there. Therefore, weight bearing views with sometimes an extra view of patella is ordered as well, and that is the merchant view or sunrise view of the patella, to see what is the situation of patella and its undersurface, how it is actually articulating in the trochlear groove as well. Therefore, all that has to be assessed, and x-ray AP view is seen in this, and then you assess how much actually the arthritis is there. Now, grade 0 according to the Callaghan and Lawrence system is there is no joint space narrowing, there is no reactive changes, and there is no associated osteophyte formation. There are actually three things you look at it: how much osteophyte formation is there, how much joint space narrowing there, and how much reactive changes are around in the bone present. In grade 1, there is mild joint space narrowing, but there is no osteophyte formation and might be some signs of reactive changes as well. In grade 2, there is definitive joint space narrowing, there is some formation of osteophytes as well, and some degree of reactive changes as well. In grade 3, there is moderate osteophyte formation, definite joint space narrowing with definitive reactive changes as well. And when it comes to grade 4, this grade 4 means markedly reduced joint space, large osteophyte formation, and massive reactive changes as well. The reactive changes are actually seen around the joint space as well as in the subchondral bone, which includes subchondral sclerosis and subchondral cysts. When we are talking about the joint space, it will eventually get narrow and eventually lead to the two bones colliding with each other during every movement, leading to further wear and tear of the cartilage. And what we look for is the formation of osteophytes. This may be small like this, or there may be a large and multiple osteophyte formation as well. That is how we grade this osteoarthritis on the x-ray AP joint from 0 to 4. If you see this x-ray, this is the lateral view. You can appreciate that there is an osteophyte over here as well. There is reactive sclerosis which can be seen in the subchondral bone, as well as if you see patella, there may be large osteophyte formation over there as well, along with the eburnation of the bone as well. If you see this is further x-ray, you can appreciate large osteophytes involving the knee joint. There is some knee joint osteophyte formation over here as well, massive sclerosis and whitish which can be seen, and the subchondral bone and reactive changes are seen along with the patellofemoral joint as well. Therefore, usually knee pain, stiffness, swelling along with the genu varum and x-ray changes are usually more indicative of osteoarthritis in the patient who is old age, probably in the late 40s or even the early 50s and the sixth decade of life as well. Other clinical features include effusion, which may get infected, and infection may lead to septic arthritis as well, but usually rarely gets infected, and patient may present with a sort of a mild swelling and effusions of the knee joint, with which may involve both the knee joints as well, as sometimes osteoarthritis is not a systemic problem, but it can affect multiple joints as well. Then comes the synovitis. Synovitis and synovial hyperproliferation is common and leads to increased synovial joint fluid production, eventually leading to effusion and swelling as well. As swelling has increased and synovial hyperproliferation has increased, this leads to movements becoming increasingly limited. In case of the osteoarthritis, there may be decreased extension of less than 5 degrees. Normally a person, if this is the 0 degree, person can hyperextend a knee about 10 degrees, but in the case of osteoarthritis, even the 5 degrees of extension may not be possible as well. And when it comes to flexion of the knee joint, normal flexion is about 130 degrees, but there is definitely markedly reduced flexion as well, and the flexion in the knee joint may be less than 110 degrees. Therefore, usually this is from -5 to 110 degrees is usually the range of motion, and it may be more severely affected as well. Then crepitus. Why crepitus was formed? Because underlying patellofemoral and tibiofemoral joints may have formation of osteophytes, increased sclerotic changes, and this whenever they move, for example, during flexion extension, the surfaces may rub against each other and may eventually lead to crepitus formation. And usually it's very much visible on the examination as can be very easily felt on the examination as well. Then loss of terminal extension is very important sign. Usually about 10 degrees of extension is possible or hyperextension is possible at the knee joint. But if the patient is unable to extend, this is a sign that probably osteophyte formation has, because anteriorly sometimes the osteophytes, large osteophyte formation occurs, and they kind of put a mechanical block for the tibia to hyperextend itself. And then fixed flexion deformity. Patient eventually may develop fixed flexion deformity as well, because both the flexion and extension are affected, and eventually keeping in certain posture for pain relief and to decrease the swelling and to decrease the problems associated with osteoarthritis. This patient eventually may develop a fixed flexion deformity of the knee joint. And sometimes the patient comes to you with fixed flexion deformity, but when you investigate further and you get the x-rays done, you realize that actually the problem was osteoarthritis, which has kind of a complicated into a fixed flexion deformity and limb discrepancy in the case of patient. Then when we get an x-rays, this is the kind of a picture you see. Again, if you see, this is no marked joint space narrowing, there is very little reactive changes, there are probably no osteophyte formation. But this is, if you compare this side with this, you can appreciate there is definitely some joint space narrowing which can be seen, and from grade 0 probably this has progressed to grade 1. There is marked joint space narrowing with reactive changes, although we cannot appreciate osteophytes here. But if you see this, there is definitely joint space narrowing, osteophytes formation, subchondral sclerosis can be seen. And this is how you grade x-rays. Although there is not absolute method, there are multiple ways of actually grading the osteoarthritis in knee joint, but usually Caligran and Loris system is most commonly used. Then we have to go for an MRI as well. Why? Because sometimes when the patient comes with locking, catching sensation, there may be underlying meniscal injury for which the patient may be having these symptoms mimic osteoarthritis as well. Therefore, if we are suspecting certain meniscal injury or in the intracapsular ligamentous injury, then we may have to go for an MRI to rule out that whether it's definitive, to make definite diagnosis of osteoarthritis as well. Then once we have made the diagnosis, then comes the treatment. And as opposite to rheumatoid arthritis, the mainstay and the main doctor who is treating the rheumatoid arthritis is a rheumatologist. And as an orthopedic surgeon, we are only dealing with the complications. But in the case of osteoarthritis, We are the mainstay of all the treatment, whether it's conservative or it's surgical. And whenever the patient comes to you, then we have certain guidelines. For example, American Association of Orthopedic Surgeon guidelines for knee osteoarthritis is there, and they recommend to start with the non-operative treatment, especially the NSAIDs and COX inhibitor. First of all, you consult the patient about the disease, how it's going to progress, what are the other signs, symptoms which may eventually appear, and what else we need to do. From if all this treatment fails, how are we going to proceed with our surgical plan. Detailed information counseling is of utmost important because patient will require rehabilitation. Patient needs to be counseled properly so that patient can actually participate in rehabilitation, because rehabilitation if fails, that would actually result into poor surgery, because poor surgical results leads to more problems for the patient. If the patient is not motivated enough, this would lead to a poor surgical outcome. Then comes the exercise. Rehabilitation exercise are the mainstay of the treatment. For example, if the patient is obese, you ask them to exercise and lose weight, because loss weight reduction as well as exercise and counseling are the mainstay of the conservative therapy. Why weight loss is important? Because you need to reduce the mechanical stress which is actually occurring on the article surface. Although some degree of deterioration would be present, but weight reduction would actually decrease the forces which are acting on the knee joint, therefore decrease the progression of the disease. Then comes exercise, physiotherapy, and weight loss. All these are interlinked. And for the patient to be motivated enough to reduce weight, to get proper physiotherapy and exercise, you need to counsel the patient properly. Until unless the patient is properly counseled and told about the disease, patient will less likely to participate in the exercise, physiotherapy, and weight loss regimen, and eventually lead to failure of the conservative therapy. Then comes the medications. The mainstay of the medications is initially the analgesics, which includes NSAIDs and COX inhibitor. Although tramadol can also be given, and NSAID and tramadol are mainly used to actually augment, because NSAIDs have a problem, affects the renal system as well. They may have a lot of problems with GI disturbances as well, because these patients sometimes require medication over a prolonged period of time, maybe 3 months, 6 months, a year as well. Therefore, what is important to understand is that this patient eventually will have to be shifted to centrally acting drugs because of the nephropathy. And patient may be having underlying renal problems as well. Patient may be diabetic. Therefore, we have to title actually our effect of NSAIDs and tramadol, which needs to be given more. Then comes the walking sticks and walking aids. Walking aids are important because they actually offload the weight which is actually being transmitted through the joint. For example, if the patient is having isolated right knee arthritis, patient can use the walking stick on the right side. Now, what would this do? The weight would be transferred from the shoulder hand to the walking stick rather than being transferred to the right knee. And patient can bear the other way, partial weight on the left knee and mostly on the walking stick. This would actually offload a lot of the pressure from the knee and would actually lead to decreased pain and sort of a much better life for the patient as compared to when the patient is wearing all the weight on the same knee. Then other options could be knee offloader brace as well. The mechanism of the walking aid sticks and all this is actually the same, that you offload the weight bearing surface. Why? Because if the less force would be transmitted through the knee joint, there would be less cartilage destruction, less reactive changes, and eventually decreased progression of the disease, and once therefore decreased pain as well as the symptoms which would appear of the patient. Then intra-articular corticosteroid injection is also indicated, and it's sort of an adjunct treatment, although it not completely cures the disease, but it does delays the progression of the disease in the local environment. But giving it is important, although there is a debate going on of causing ligamentous injury as well during the intra-articular injections, but you need to be careful when you're injecting, intraarticular steroid injections. Then American Association of Orthopedic Surgeons has not recommended the use of acupuncture, chiropractic techniques. There was a debate probably 4 or 5 years ago of using these adjuncts as well. There was use of hyaluronic acid and glucosamine and chondroitin sulfate injections as well. But all these viscoelastic injections there's no actually concrete evidence that they really help. Therefore, because over the period of time, there has been sort of we can say the doctors have been a bit of a reluctant, or even the patients have been reluctant as well, to straight away go for surgery. Therefore, a lot of in-between treatments have appeared. For example, right, starting from the NSAID, exercise and physiotherapy, and if that doesn't work, they go for intraarticular steroid injection. Now, if the steroid injections do work, but what happens is, for example, if the first injection was given today, probably the patient would come again after 6 months to 1 year time. And if you give a second injection, and after the second injection, the patient will come quite more early as for the third injection as compared to the second injection. If he or she came about after 1 year for the second injection, there is likely that for the third injection she will come after 3 to 4 months. And even for the fourth, its efficacy goes down as we progress to multiple injections. Then there was sort of a time in between. There were a lot of viscoelastic injections which came in. For example, injecting hyaluronic acid, hyaluronic chondroitin sulfate, and glucosamine sulfate as well. And these viscoelastic injections were injected into the knee joint, but eventually it was found out there was no real benefit as compared to intraarticular steroids. So nowadays, if the steroids are not becoming effective, you move towards the surgical treatment rather than lingering the patient towards more misery and like kind of not properly completely treating the patient, as well not completely leaving it out as well. Then comes the surgical treatment, and this arthroscopic lavage and washout was one of the treatment. Although it's not a pure absolute cure of the disease. It does almost the same thing what is being done with intraarticular steroid, that is slows down the progression of disease. You go in arthroscopically, that is you're making small incisions, giving mini incisions, not really damaging, giving a large cut and opening up the whole knee joint. You go in, you debride all the areas which are actually in which the articular cartilage has been destroyed, so that the subchondral bone and all the synovial hypertrophy is actually removed. And then so one other way of doing it is just giving it a lavage and cleaning it up and properly, and that actually helps to in a way that patient may be pain free for about quite a long time. But again, patient will eventually become painful, and eventually this has to be repeated. But this is not the absolute cure of the disease. The patient would require multiple other washouts, and eventually this washouts may be not completely effective as well. Then comes the mainstay of the treatment is actually arthroplasty. Now arthroplasty there are multiple options as well. One is total knee arthroplasty, or other is a unicondyle knee arthroplasty. This unicondyle knee arthroplasty has its own indication. For example, if a patient is old age and has isolated single condyle involvement, for example, the patient's lateral condyle is absolutely fine, patellofemoral joint is absolutely fine, there is only arthritis which is present over the medial aspect of the knee joint because of the gene variant and the forces being transmitted through this, then these kind of patients are kind of candidates for going for unicondylar arthroplasty. But again, it has its own limitations and indications as well. For example, if there is multiple patellofemoral as well as other compartment arthritis, then this unicondylar knee arthroplasty is ineffective. For example, if the patient is obese or overweight, this unicondylar arthroplasty is ineffective because it was fail under the load as well. Then in a limited set of a population, unicondylar arthroplasty can be a very good option, especially if they have isolated arthritis of the single compartment. But usually we have to go for eventually our mainstay of the treatment for osteoarthritis and the knee joint is actually the TKR, or total knee replacement. Other options which have been tried are high table osteotomy, although it's rarely done. But again, like unicondylar arthroplasty, this high table osteotomy has also its own indication and contraindication as well. In young patients, for example, if a patient develops arthritis quite early in, let's say, late 30s and early 40s, now, if you go for TKR, there is a chance that this would go eventually would require replacement very early, because in the late 30s or in early 40s, the patients are quite young and quite active as well. Therefore, if before the age of 50 and usually involving the medial compartment, we can go for this valgifying high tibial osteotomy, in which we can offload the medial compartment, which is actually mainly the fatty. But high tibial osteotomy can also be done of offloading the lateral compartment as well, but usually it has its own indication and contraindication as well, and it's usually done in the younger patients. Problem with this high tibial osteotomy is that this plate would later on require removal surgery as well. Plus, biomechanics sometimes get disturbed as well. There's problem with the maintaining of the posterior tibial slope as well, and all these systems actually come into play as well. Again, high tibial osteotomy and unicondylar knee arthroplasty is only effective in a certain subset of a population. It's not effective for everyone. What is effective for everyone is actually the total knee arthroplasty, and that is our replacement arthroplasty, which is done for every knee osteoarthritis or even the rheumatoid arthritis as well. Nowadays, there is with a lot of research being put into PS knee or posterior stabilized knee, or CR knee, that is a cruciate retaining knee, in which the PCL is actually left intact. But then again, all these with semi-constrained knee like this, in which there is a completely hinged constrained type of knee prosthesis, have come up, especially because the indication for knee arthroplasty has actually expanded over the period of time, with the problem with the joint subluxation, instability as well. Now these constrained hinged varieties can be done for even these kind of knees as well. Therefore, over the period of time, mainstay of the treatment of osteoarthritis is total knee arthroplasty. If you see over here, the patellar resurfacing was not done, but again, this is also a debate whether to go for patellar resurfacing or not to go for it. Sometimes some advocates of patellar resurfacing say that there is always some degree of patellofemoral arthritis, and when you're done with the TKR, a major surgery, and don't do the resurfacing, patient will complain of pain in the patellofemoral joint, and patient will have sort of a poor score on the visual analog scale because of the patellofemoral arthritis. And when you're doing such a big surgery, you can easily go for resurfacing as well. But according to the opponents, what is not required, you should not be doing it often. Again, there is no real, you can go for patellar resurfacing and you cannot go for that. Depends upon the surgeon's preference more than actually there's a concrete evidence of doing it or not doing it. Now, last option, which is again, there are certain options which are discussed, but they're rarely done. For example, you will not see a lot of high tibial osteotomies for knee arthritis. There will be definitely very few cases of unicondylar arthroplasty as well. Similarly, the case of orthodesis. Nowadays, as the prosthesis for TKR has actually expanded, therefore the arthrodesis have actually become rare, and the indication for arthritis has actually reduced. Until unless you have failed TKR twice and you are unable to control the infection and a massive problem with the patient, then you can go for arthrodesis as well. But probably 30 or 40 years ago, to kind of relieve a patient of a chronic pain, arthrodesis was the mainstay of the treatment. The patients used to be given arthrodesis, pain was gone. Although once the joint was ankylosed, the problem was with the movement, but patient would be able to walk with the sticks and everything else. But nowadays, with newer generation of prostheses available, which can not only rotate like a normal knee joint as well during the flexion extension, with next generation of second and third generation of prostheses available, arthrodesis indication have actually reduced, and it's rarely done nowadays. We have briefly covered rheumatoid arthritis as well as osteoarthritis over today. What is important to understand is that these two diseases are sort of systemic problems, and you need to get detailed history as well as examination, and you need to assess other joints as well. Osteoarthritis may not be involving the knee; it may be involving other joints like both the knees or the ankle or the ipsilateral hip as well. Therefore, detailed history, examination, assessment, and then getting to the radiological workup, because that is very important for both the rheumatoid as well as osteoarthritis. Once you have made the diagnosis and ruled out other causes of knee pain, swelling, and stiffness, then you can proceed towards the treatment. And initially, for both of them, involves conservative treatment. For rheumatoid arthritis, it's the DMARD, which is the mainstay of the treatment, along with the physiotherapy and loading braces as well. But for osteoarthritis, it is the weight reduction, offloading mechanism, use of walking aids, offloaded braces is the mainstay of the treatment. But once rheumatoid arthritis has complicates to further in which the life becomes miserable, or osteoarthritis has progressed to a point where the surgery becomes indicated, the mainstay of the treatment is joint replacement surgery. Although different other types of surgery, which is specifically indicated for certain subset of a population, may also be done. Thank you very much. Keep watching sqadia.com.